Welcome to the Deep Dive. We're here to pull out the key insights from really critical research, helping you understand what truly matters. Today, we're tackling a global public health crisis.
Yeah, one that hits developing nations particularly hard. Traumatic brain injury, or TBI.
Right, TBI.
And just so we're all on the same page, TBI is basically an acute event. Some kind of external mechanical force disrupts how the brain normally works.
And it's serious stuff. It's the leading cause of death and long-term disability from traumatic events across the globe.
Absolutely. The consequences are often devastating, things like chronic cognitive issues, behavioral disorders.
Yeah.
They change lives forever.
And there's a huge disparity here, isn't there? The numbers show TBI cases are almost 3 times higher in low- and middle-income countries, LMICs, compared to high-income ones.
That's right. And that disparity, it becomes lethal when you look at the outcomes. TBI-related mortality rates, they're 3 to 4 times higher in LMICs.
Wow, 3 to 4 times.
Yeah. So we're not just talking about more injuries happening. We're talking about, frankly, catastrophic system failures that lead to vastly more people dying from these injuries.
So to really understand what's driving this, our mission today is to dive into one specific, very telling study. It's prospective cohort data out of Bangladesh.
That's the Rahman et al. Study from 2025. They tracked 659 TBI cases at the country's biggest teaching hospital, DMCH in Dhaka.
And this study, it sort of acts like an X-ray, doesn't it? It shows us the specific failures driving those terrible mortality rates, which likely reflect issues across many similar settings.
Exactly. It gives us a really granular look. So let's start with just a quick snapshot of who was in this study.
Okay.
The average age was tragically young, just 32.3 years, and overwhelmingly male, about 80% of the cases.
So working-age men, really, the most productive group in society, being hit the hardest.
Precisely. And the cause of their TBI, overwhelmingly clear. Road traffic injuries, RTIs, they cause 62% of all the TBI cases.
62%, that's huge. What were the others?
Much lower. Physical assault was next, around 17%, and then falls, around 16%. And for this whole group, the overall death rate was just over 10%, 10.3%.
Okay, so let's focus on those road traffic injuries then. RTIs.
Right, because when we break down the causes, RTI isn't just the most common way people got TBI in this study. The data shows it's also the most vulnerable mechanism, the one leading to the worst outcomes.
Okay, unpack that a bit. More vulnerable, more severe. Why? Does the study get into whether it's about, like, the speed involved in crashes versus a fall, or?
It's likely a combination factor, speed, type of impact, definitely. But the clinical data is stark. Patients whose TBI came from an RTI, they had almost double the odds, 1.95 times higher, of presenting with a severe head injury right from the start, compared to TBI from other causes.
So they're already in a much worse state when they arrive for help.
Exactly. They start the medical journey far, far worse off.
And that translates directly to survival chances, I assume.
Directly. Mortality among those RTI-related TBI patients was 3 times higher than for patients whose TBI wasn't from a road incident.
3 times. That's just... It screams road safety crisis, doesn't it?
It absolutely does. And the vulnerability, it stretches way beyond just immediate survival. We also need to look at the long-term cost. The study used the Glasgow Coma Scale, the GOS, for that.
Right, the GOS.
Yeah.
For our listeners, that basically measures how independent someone is after the injury, their quality of life.
That's it, exactly. And RTI patients were almost twice as likely, 1.9 times, to have a poor outcome on the GOS.
Poor outcome, meaning?
Meaning they ended up either dead in a persistent vegetative state or permanently dependent on others for just basic daily life activities.
Wow.
And on top of that, they were also 1.7 times more likely to suffer from long-term post-traumatic anxiety. So this type of injury, it's not just killing people at a higher rate, it's severely limiting recovery and quality of life for those who do survive.
Okay, if RTIs are the main driver here, let's zoom in. Who are the victims on the road?
Well, the majority were pedestrians. Actually, 43.8% of the RTI-related TBI cases.
Pedestrians.
Drivers were next, at 28.3%. So, yeah, it really confirms that the least protected road users are the ones most likely to get these severe head injuries.
Then what about the vehicles involved? Any patterns there?
Motorcycles were a big factor, responsible for just over a quarter, 27.1% of the cases.
Motorcycles, okay.
And almost all of these incidents, 94.8%, happened on main roads, high traffic roads. So you combine motorcycles, pedestrians, main roads. It paints a picture of the most vulnerable people in the most dangerous spots bearing the brunt of this trauma.
And when you layer on that demographic data, average age 32, mostly men, we're really talking about a massive loss of potential, aren't we? Economic, social.
Absolutely correct. The data really confirms it. Young men, in their most productive years are the most vulnerable, likely due to, higher exposure from work, maybe riskier travel habits for their jobs. It underlines that TBI isn't just a health crisis. It's deeply economic and social too.
Which brings us to maybe the most critical question. Once that injury happens on the road, what actually determines if someone lives or dies?
Right. And the researchers looked really closely at this for the RTI cases. They did logistic regression analysis, and something really key emerged.
What was that?
Sociodemographic factors, things like the patient's sex, their education level, even their income, they had no significant predictive impact on mortality in this analysis.
That's quite a finding. So once the crash happens, their background doesn't statistically determine survival.
Not in this model, no. It suggests that once the injury occurs, those factors fade into the background. What becomes absolutely critical are the clinical details of the injury, and maybe even more importantly, the system's response.
Okay, so let's break down those critical predictors the study identified. There were three major ones, right?
Yes, three key factors linked to mortality and RTI-related TBI. The first one, and it had the biggest impact, was the initial injury severity measured by the GCS score, the Glasgow Coma Scale.
GCS, and how significant was that?
Hugely significant. Patients who came in with a severe GCS score that's defined as less than 8, they had a massive 8.1 times higher risk of dying compared to patients with mild or moderate scores, which are 9 to 15.
8 times higher risk. For listeners maybe not familiar, what does a GCS score under 8 actually mean in practical terms? What does the patient look like?
Functionally, it means they're largely unresponsive. They might only respond to pain, or not at all. They often can't protect their own airway, meaning they can't cough or swallow properly to prevent choking. They need immediate, intensive medical help just to maintain basic functions like breathing.
Okay, so it flags the most critical patients right away.
Exactly. It really underscores how vital the GCS is for that initial triage. If someone comes in with a low GCS, the clock is already ticking incredibly fast.
Okay, predictor number 1, severe GCS. What was the second factor?
The second was related to consciousness, specifically loss of consciousness or LOC.
How long they were unconscious.
Precisely. Patients who lost consciousness for more than 1 hour had 3.4 times higher mortality.
3.4 times. So the duration matters a lot.
Yes, it's a clear, early clinical sign pointing to the severity. A longer period of unconsciousness suggests a deeper, more sustained disruption to brain function.
Makes sense. Okay, GCS score, duration of LOC. What was the third critical predictor? You said this one points more to the system.
Yes, and this is maybe the most crucial one from a policy perspective, because it's potentially modifiable. It's the delay in initiating treatment.
Ah, the time factor. How much delay?
The study found that a delay of more than 8 hours between the injury happening and getting definitive treatment started, that led to a 2.7 times higher risk of mortality compared to those who got treated within that 8-hour window.
2.7 times higher risk just from an 8-hour delay.
Yes. So the clinical factors, GCS and LOC, they tell us who is most likely to die based on the injury itself. But this delay factor, it starts to show us why they die. The system couldn't deliver the necessary care within that critical life-saving time frame.
That 8-hour window seems absolutely pivotal then. And that delay, it isn't just bad luck or traffic, is it? It sounds like a system failure.
It really is. And the study gives us some shocking details about the pre-hospital care, or lack thereof, which feeds directly into that deadly delay.
Let's get into that. What did they find about what happens right after the injury?
Well, first, basic safety measures were almost non-existent. A staggering 97% of patients reported they weren't using any safety measures at the time of the incident. No helmet on a motorcycle, no seatbelt in a vehicle.
97%. Wow.
And then immediately after the injury occurred, 92.1%, that's over 9 out of 10 patients, received no first aid or CPR right there at the scene.
So people are critically injured, lying there, and basically nobody around knows what to do or has the means to help stabilize them.
That's the picture it paints. And then comes transportation. This is also critical.
How did people get to the hospital?
None of the patients got there via a coordinated emergency transportation system, like a public ambulance service responding to a call. Zero. They all relied on personally hired vehicles, maybe a taxi, a rickshaw, or sometimes a private ambulance they paid for themselves.
Okay. And how were they transported? Any precautions taken?
That's the other alarming part. The vast majority, 93.5%, were not immobilized during transport.
Not immobilized, with a potential severe head injury, maybe even a spinal injury. That sounds incredibly dangerous.
It is. Moving someone with an unstable head or neck injury without proper immobilization, like a neck collar or backboard, can absolutely worsen the damage. It contributes to what we call secondary injury.
Can you explain that term, secondary injury?
Sure, the primary injury is the damage done at the exact moment of impact, the bruise, the tear, the initial bleed. Secondary injury is the damage that develops in the hours and days after that initial hit. It can be caused by things like the brain not getting enough oxygen, or blood pressure being too low, or swelling inside the skull. And yes, excessive movement during transport, jostling the injured brain and spine, is a major potential cause of secondary injury. It can turn a potentially survivable injury into a fatal one.
So, no first aid, transport in private vehicles, no immobilization. What happens when they finally reach a health facility?
Well, often it wasn't the right facility, or at least not the final one. Two-thirds of the patients in the study first went to a primary or secondary level clinic or hospital before eventually being referred on to the big tertiary center, DMCH.
So they're losing time bouncing between facilities.
Yes. And here's another critical finding. Over a third of them, 34.3%, reported receiving no treatment at all at that first facility they went to for being told they needed to go somewhere else.
No treatment. They just get referred on.
That's what they reported. It suggests two major problems. One, maybe the public doesn't know the right place to go for a severe injury like TBI. And two, it strongly implies that those initial smaller facilities often lack the training, the equipment, or maybe just the capacity to provide even basic stabilizing care for TBI emergencies.
So they spend precious hours getting to a clinic only to wait, get assessed perhaps, and then be told to go elsewhere without getting any crucial stabilization first.
Exactly. And all of this loops right back to that deadly statistic we talked about earlier.
The treatment delay.
Right. Almost half the patients, 46.9%, had a time gap of more than 8 hours between when the injury occurred and when they actually started getting definitive treatment. And we already know that delay correlates directly with that 2.7 times higher risk of death.
It paints a really bleak picture of the entire emergency response chain.
It does. These findings, taken together, they really reflect a profound lack of a dedicated, coordinated emergency management system. You see inadequate referral pathways where time is lost. And maybe most fundamentally, you see insufficient community knowledge about basic first aid and emergency response. The delay isn't just one thing. It's a failure at multiple points, from the roadside all the way to this specialist center.
So wrapping this up, this deep dive really highlights a dual challenge driving these high TBI death rates, at least in this Bangladesh setting, which likely mirrors others.
That's right. On one hand, you have the extreme clinical severity that often comes with road traffic injuries. They cause worse injuries to begin with.
And on the other hand, you have the catastrophic impact of delays and major gaps in pre-hospital and initial care.
Exactly. The system just isn't equipped to handle these severe injuries quickly and effectively.
The implications for policymakers seem really clear then.
They are. If the goal is to reduce that shocking 3 to 4 times higher mortality rate we see in LMICs, the focus has to be on multisectoral action to close that 8-hour treatment gap and ideally make it much shorter.
Multisectoral meaning?
Meaning it's not just a health ministry problem. You need things like enforcing road safety helmets, seatbelts, speed limits to reduce the severity of injuries in the first place. That involves transport and police.
Right, prevention.
Then you absolutely need community-based education, training people in basic first aid and CPR so immediate help is available at the scene, and crucially, building a coordinated pre-hospital care system.
So, proper emergency transport.
Yes, rapid transport with trained paramedics who can actually immobilize patients safely, manage airways, give oxygen, and smoother, smarter referral systems so patients get to the right level of care faster without bouncing around.
What really stands out to me from the study's analysis is that the factors predicting death were so strongly tied to the clinical severity, the GCS, the LOC, and that systemic failure, the 8-hour delay.
Right. While sociodemographics didn't show up as significant predictors in that specific mortality analysis for RTI patients once injured, it suggests the vulnerability here is heavily systemic, not just about the individual patient's background once they're critically hurt.
Which leaves us with a powerful final thought for you, the listener.
If the key factors determining survival, once an RTI causes a severe TBI, are predominantly clinical, like the GCS score, and systemic, like that critical 8-hour treatment delay, what kind of radical shifts could make the biggest difference?
Beyond just building more advanced hospitals, what changes in basic infrastructure, community training, and emergency coordination could immediately start bridging that time gap?
How could we save the most vulnerable lives, ensuring faster, better care gets to them, regardless of their background or where they happen to get injured?
Something crucial to think about. Thank you for joining us for this deep dive.
Thank you.
We'll see you next time.